Okay. Hi everybody. We're going to start with fluid and electrolytes this week, acid-base imbalances. So this is going to come out of chapter 13 of your Lewis textbook. So if you want to follow along, pages 237 to 284. And this is the stuff that you'll be tested on this week. Okay, so I'm just going to go through here really quick. Hopefully this won't be too terribly long. And most of this should be repeat information for you. You should have had this in physiology, pathophys, and in MedSurg 1, so this should be repeat information. However, it's hard concepts, and it's really important to understand this stuff so that you know how to apply it in the clinical setting, which is why I'm going over it again. All right, so let's go through the chapter, and then I'll tell you some of the stuff that I really want you to focus on, and some other stuff that you can kind of gloss over a little bit. On the first page, the composition of body fluids, it is important to understand that in the body, the fluids, you have the vessels that have half blood, half plasma, and together it's called whole blood, all of it together. And so you have, and inside you have the cells, like the red blood cells, white blood cells, thrombocytes for clotting. And you also have cells inside all of the organs that they do all the work. You know, they produce energy, they do whatever organ is, you know, like the kidneys are filtering urine or whatever. So you've got the intravascular space, all the stuff inside the vessel but outside the cell. Intracellular space, all the stuff inside the cell. And then it's like the transcellular space, or like the interstitial space, where there's not a ton of fluid, but there's some fluid in those other spaces of the body. That's important to know. It's also important to know which cations and anions, which are your positively or negatively charged electrolytes, are predominant inside the cell or outside the cell. So you should remember from wherever you guys got this from, physiology, that sodium is your major intravascular cation. A cation is a positively charged electrolyte versus an anion, which is a negatively charged electrolyte. So sodium is the major cation in the intravascular spaces. Potassium is the major cation in the intracellular spaces, and that's important to remember. The other thing that I want you to be a little bit, you know what, back to the cations and anions. Kind of look through table 13.1 on page 239. That's important to know. That'll tell you what the cations and anions are. And then those values there are important. Like obviously you should know like your normals, like sodium is 135 to 145, your potassium is 3.5 to 5. Those are important to know because it's really important as a nurse to be able to monitor what those lab values are doing so that you can determine if your patient is hyper or hypo, whatever electrolyte, because then you can start watching for signs and symptoms, or you can see signs and symptoms in your patient and then get the labs that will correlate, you know, are the labs causing what I'm seeing in the clinical setting. So kind of look through table 13.1. An electrolyte, just as a reminder, is anything with an electrical charge, either a positive or a negative charge. And it's most of the things on the periodic table. There's some other things in the intravascular spaces that aren't electrolytes, like your hormones. Glucose is in there. Glucose doesn't have a charge to it. Enzymes, you got a lot of enzymes that your body produces, different enzymes. Those are not electrolytes, but they're also in the bloodstream. Anything that you can draw, like when you're drawing your patient's blood, if you can draw it and get it in a vial of blood and send it to the lab, that's in the intravascular space. So there's a lot of stuff in there. But right now we're going to focus on the electrolytes. The other thing that I want you to know about for the fluid composition of this is how fluid transfers between these spaces that I was just telling you about, the vascular space, the cellular space, and then outside of the vascular space. That's really important to understand. So I want you to focus on the concept of osmolality or osmolarity. Those are almost the same thing. And the concept of diffusion. That's really important, especially when we're going to start talking about the different kinds of IV fluids, isotonic, hypertonic, hypotonic, because the concept of diffusion and osmolarity, that has everything to do with shifting of water across those membranes, or the shifting of solutes across those membranes. And when I say solute, I mean anything that's not water. So like your electrolytes, enzymes, hormones, all those things that I just told you about, those are solutes, and those are the things that you will find in the intravascular or intracellular spaces. And inside those spaces there are normals. So there are certain things like in the intravascular space, you should have between 135 and 145 milliequivalents of sodium per liter. That's a normal. So that's how you can tell if it's too high or too low, and the problems that come with it if something is out of whack. So look through where it says regulation of body fluids. Kind of understand osmosis and osmolality, and I'll go over that a little bit with you. The sodium-potassium pump, kind of look over that. The filtration and diffusion, don't spend too much time on that, other than knowing that solutes and fluids shifts back and forth, and your body has amazing mechanisms in place to try to maintain equilibrium, and it will do all it can to maintain equilibrium, because your body knows how much water is there and how much volume and solutes are in certain areas. Your kidneys are the key organ for fluid regulation. So urine output and weight. Urine output, because the kidneys will sense, like, if you have way too much water, you're going to start urinating a lot more, and if you're hypovolemic, you have less fluid or less water, then it will hold on to that, and then your weight goes up. So those are your kidneys have everything to do. Not everything. You have some insensible water loss, like every time you breathe, you lose vapor, you lose water that way throughout the day. Your patients will sweat and they'll lose water that way. So you have other insensible water losses, and that's approximately 600 cc's, 600 to 700 cc's a day of insensible water loss, plus whatever your patient is actually excreting in urine. Or if they're also having emesis and vomiting, that also has to get included in water output, because your patient will lose a lot of water through vomit and diarrhea. And we'll talk a little bit more about that with acidosis. So look at page 240 and you'll see what I mean about osmosis and diffusion. Osmosis is water moving one place to another to try to maintain equilibrium, because across those membranes, the water and the solutes tries to be exactly the same. All of the membranes, either if it's the vascular membranes or if it's the cellular membranes, they're very friendly and they always share. So they want to be equal. So like in diffusion, if there's more solutes on one side, fluid levels are the same, more solutes are on one side, by the process of diffusion, the solutes will slide across that membrane onto the other side, so that the solutes are the same and the fluid's the same. Same thing is happening in osmosis, where there's more water on one side and less, and the water shifts across so that the water and the solutes equal out. So your body does that all day long. So on page 241, if you'll notice under laboratory tests for evaluating fluid status, the one that I want you to kind of focus on is the urine-specific gravity. That's important. Your urine-specific gravity should be between, they base it off of like distilled water, which the specific gravity of urine should be between 1.010 and 1.025. The more dehydrated your patient is and the more concentrated the urine is, the higher the specific gravity numbers will be. the more fluid your patient has. The patients who are hypervolemic, fluid overloaded, their urine will be diluted and their specific gravities will be lower. That's an important number. You don't need to figure out this, you don't need to figure out the approximate value of serum osmolality. Look at that equation in the middle of the page there where it's sodium times 2, glucose plus blood urea, nitrogen. You don't spend any time memorizing that. It's way too complicated. What I do want you to look at a little bit is table 13.3, where it goes into the factors that will affect serum, meaning blood, and urine osmolality, because it's important to know if your patient is dehydrated, if they've sustained a crush injury, a burn, if they have cancer, if they've got a pancreatic problem. That can affect the urine or the serum osmolality. And if you understand osmolality and diffusion, you'll understand that if the volume goes low in one area, fluid is going to shift out of another area, and you as a nurse have to follow that because you're going to have to fix whichever abnormality is going on. So spend a little time looking at table 13.3. The other, your kidney functions, on page 242 now, go over that, just briefly skim over that, because that talks about the different organs that contribute to fluid retention or fluid loss. That's should just be a review from anatomy. You don't really have to spend a ton of time looking at that. I do want you to understand the renin-angiotensin-aldosterone system. I love that system. It is such a cool system. And there's a diagram of it in figure 13.2. However, this diagram I think is a little bit complicated. I have a really good diagram. I'm going to put it on Blackboard for you that explains this renin-angiotensin-aldosterone system. The thing that I really want you to focus on, and you might have learned this from last semester when you were studying hypertension, is the part where you have the angiotensin converting enzyme known as ACE. When in the presence of an angiotensin converting enzyme, it goes up into the lungs and recognizes that it's there and sends down angiotensin converting or angiotensinogen 2, which causes vasoconstriction. So when you're giving your patient an ACE inhibitor, that's the point of that cycle where it'll stop it. So your patient who is who has high blood pressure and they have been prescribed an ACE inhibitor, that's what's happening. And I'll show you, go look at the other PowerPoint that I'm going to show you on Blackboard, because it really makes a lot of sense. But that's what happens, is that the angiotensinogen system causes vasoconstriction, and if you can stop that with an ACE inhibitor, you can cause vasodilation, and you can prevent hypertension, which is a great drug, until you need that system to work. So let's say your patient has hypertension, they're on an ACE inhibitor, and all of a sudden they are in a car accident and they are hemorrhaging. Now all of a sudden you want that system to work, you want those vessels to constrict, to retain fluid loss. So if you have a patient in that condition and their vessels can't constrict because they're on an ACE inhibitor, you need to stop that ACE inhibitor really quickly, or find out that they're on it so you can give them other medications so that their vessels will constrict. So that's a little off topic, but it's important for you to know. It is really important to understand the geriatric considerations in your patient when you're discussing fluid volume, because they don't respond the same way that a non-elderly person would. By elderly, usually it's 65 and older, but then there's the very elderly, which a lot of our patients are in now, is 75 and older. Patients in that category, they don't have normal skin turgor. And somebody, a young person, you should be able to tent their skin and it immediately goes right back down. Well, if you try that on an old person, you can pull it up and then it just kind of stays up like that. It doesn't necessarily mean they have a fluid problem. It just means that they have saggy old person's skin. So you can't really use skin turgor as a good assessment in the elderly when you're looking at their fluid status. Also, the elderly lose their their sense of thirst. So whereas you or I, if our sodium levels get high, if we're starting to get dehydrated, our kidneys send signals up to the hypothalamus and says, oh, we don't have enough fluid here, make them thirsty, and so then you go and get something to drink. That process doesn't occur in the elderly, so it might not be for a very long time before they realize that they need to drink. So it's important to make sure that you are encouraging your elderly patients to drink fluids. The other problem is that a lot of elderly people have problems with incontinence, so they'll deliberately not drink fluids so that they don't embarrass themselves. With incontinence. So you really need to address all of those issues. And there's a lot of things. There's Depends people can wear. You can have them, drinking just small amounts throughout the day. Drink when they're near an area where they can get to a restroom. Things like that. The number one thing with patients, elderly patients, is, and this goes to sodium, and I'll tell you about that in a minute. When your elderly patient starts getting dehydrated, before they get thirsty, they may get irritable, crabby, disoriented. It could be because of sodium. Because when you have too high or too low of sodium, the number one symptom for sodium abnormalities is neurochanges. And by neurochanges, I mean anything from increased irritability, forgetfulness, complaints of feeling like they're in a fog, things like that. You might need to check the patient's sodium, and this goes up exponentially in your patients who are elderly. So, which gets a little tricky because sometimes they may already have an element of dementia, so now you don't know. Like, is it just their dementia, or are they really dehydrated? So it becomes a little bit more challenging. So do read through that gerontological considerations. And then the next sections in the book are about the fluid volume disturbances. It is really important as a nurse to know if your patient is hypervolemic, has too much fluid, or hypovolemic, not enough fluid. And when a patient, so read through that. Read through hypovolemia and the medical management of hypovolemia. And I love this table. And really, if you don't want to read through it, just go right to this table, table 13.4, where it'll tell you what is the imbalance. Are they hypovolemic, hypervolemic, hypernatremic? It'll tell you what could be some contributing factors, what are the signs and symptoms, and what lab values would go along with that. This is really, really a good table, and I would recommend that you guys use this when you're developing your care plans in the clinical setting, because there's really rich, valuable data in there. So I would spend some time studying and learning that table. The next thing that I wanted to talk about was, okay, hang on. So the next couple pages, you got hypervolemia. Yeah, and so then, and then it goes to the electrolyte imbalances. I'm going to come back, remind me, I'm going to put a little tag in here. I'm going to come back to this table 13.5 that talks about what IV fluids to give, because that's important. But it kind of is when we talk about the kinds of IV fluids. So I'm going to come back to that one. So let's skip over to the electrolyte imbalances. So the first one is sodium. Your normal sodium should be 135 to 145. When your sodium starts getting out of whack, like I just said, you're going to see neurochanges. That's the first symptom for sodium imbalances. Sodium often follows water. So, if you have if you have a lot of fluid loss, like water loss, you're going to have a lot of sodium loss. You're probably going to see a lot of hyponatremia, and vice versa. I wanted to draw your attention to figure 13.4 on page 252. I love this figure. This is a really good figure, and let me just explain this to you. So, in your patient who has hyponatremia, and keep in mind that your sodium is your major extracellular electrolyte, your cation. So you're supposed to have between 135 and 145. When that gets low, And oftentimes that's in the presence of hypervolemia. You have too much fluid, not enough sodium. So then remember, go back to osmosis and diffusion. What happens now is inside the cell, the water is going to try to get inside that cell, because outside the cell is too much water. Inside the cell are too many solutes. So by the process of osmosis, that water is going to try to get inside that cell, and those cells are going to start to swell. That's what's occurring in your patient that is hyponatremic. In your patient that is hypernatremic, now I have too many solutes, too much sodium on the outside of the cell, so the water and the solutes that are inside that cell recognize it, and the little solutes, remember, like I said, they all want to share. So the solutes that are out, like inside the cell with too much water, like, you know what, we're going to share our water with the outside of the cell, so that the solutes on the outside of the cell are not as compact. But the problem is that causes the cells to shrink. Either one has implications to it. But this process that's going on there is exactly what your IV fluids do, which we'll talk about in a little bit, which is why it's so important that you understand, if you're giving a fluid that's isotonic, meaning there's no shift of fluids, there's not going to be water or solutes going anywhere, or if it's a hypertonic IV solution, and in a hypertonic IV solution, you have more solutes going in that bag than is in the patient, and it's going to cause cells to shrink. Or a hypotonic IV solution has less solutes, more water, and is going to cause the cells to swell, because the water is going to go, or the solutes are going to go out from the cell into the intravascular space. So hard concept to understand. You got to kind of go through it a couple times to fully understand it, and we're going to come back to it when I talk about IV fluids. But make sure that you understand what's going on in figure 13.4. It is important to know nursing implications of when your patient has high or low anything. So if it's low, we're going to do sodium replacements. If it's high, we're going to, restrict our patients. Do look through anything that is in your textbook with that little red flag in there that says a quality safety alert. I want you to pay attention to that. Those are really important for you to know. Okay, so then let's go over to potassium. So your potassium is your major intracellular cation, 3.5 to 5. Potassium has everything to do with muscles, but your cardiac muscle is especially sensitive to potassium abnormalities, especially if it gets too high. So you're more likely to have bad dysrhythmias when that potassium level gets pretty high. You don't have to know over here on page 255, you don't have to, like, I'm not going to ask you to interpret any EKG changes, but it is important to know that you can have the development of U waves, you can have spikes in your T waves, you can have flattened, elongated P waves, because those, remember how we talked about the electrical conduction of the heart, those are very sensitive to normal potassium levels. So watch that in your patient. Also, besides the outside of the cardiac muscles, you can have tetany, you can get muscle cramping or muscle weakness depending on if your potassium is out of whack. So that's what potassium, I want you to remember about potassium. There are some ways to treat potassium. If it's low, it's easy. You can just increase the amount of potassium in somebody's diet. There's certain things that cause potassium to get out of whack. Certain cancers, pancreatic issues can cause both potassium and sodium to get out of whack. But you have to be careful when you're replacing potassium. You can never IV push potassium. You can only drip it in slowly, so it's not uncommon to see like maybe 20 milliequivalents of potassium added to an IV bag, and that'll make it a hypertonic solution, but that's sometimes if somebody's potassium is low, you would want that. You have to run potassium in fairly slowly, and it starts burning and stinging, so one little nursing intervention you can do is get a warm cloth. I used to take them and I put them in the microwave, like a washcloth, get it wet, put it in the microwave at work or warming drawer, whatever they have, and put that on the vein as the potassium infuses, because it does kind of hurt. And you want to make sure that if you're infusing something through an IV, some of them, especially like calcium, can cause a lot of tissue erosion if it gets outside the vessel. So you need to be very, very careful that it's actually in a vein. And it's usually a good idea to put it in, you know, a little bit of a higher vein as opposed to some of these smaller hand veins. So do go through what you're going to see in your patient if that potassium is too high or too low. Then let's look at calcium imbalances. The thing I want you to remember about calcium is that calcium has an awful lot to do with nerves and nerve functioning. Most of the calcium is found in bone, and there's a little bit that floats around in the bloodstream. And as you know, calcium has everything to do with bone and teeth and, you know, the ortho structures. So you want to keep a lot of it in the bones, which somebody who has bone problems like osteoporosis, where their bones are getting much more porous, we can put them on something that like a calcitonin. Calcitonin is great because it helps the calcium, the reabsorption of calcium helps improve bone strength. However, you don't want to put somebody on calcitonin who has low calcium levels, because when you're getting a calcium level, you're drawing it from the blood. If their calcium level is low, you might need to stop the calcitonin, because the calcitonin will cause the calcium that's in the bloodstream to go into the bones. That's the whole point of calcitonin, which it's great in your patient who has osteoporosis. It's not great in your patient who has hypocalcemia. The classic way, there's two classic ways you can identify if your patient has hypocalcemia. One is Shavik sign, and remember what I just said, that calcium has everything to do with nerve functioning. So, you know, all the nerves that go out through the body, they need calcium to help transmit the impulses that are going down those nerves. So one way to check for that is to test the facial nerve, and you just kind of tap on it and somebody's face will kind of go like that. It could be a sign that they have a calcium problem. The second way to do it is to put a blood pressure cuff on the patient's arm and pump it up all the way up so it's higher than systolic pressure, and then the person's hand will start doing this. That's Trousseau's sign. There's examples of it in figure 13.6 on page 259. Those are classic ways to find out that your patient may have a calcium problem. And there's, this thing, the chart, how to figure out this corrected serum calcium level. You're not going to be required to know that, other than in the back of your head know that sometimes, like, what you think is a regular calcium level is actually even higher, and you might need to be, you know, a little bit more vigilant about that. Because too high or too low of calcium can create quite a problem because of the nerve, how much the nerves love calcium. Calcium's easy to get in your diet too, though. And people who are dairy or lactose intolerant, they can just take the calcium tablets. Okay, so you can go through that. Magnesium is another important cation. Magnesium has a lot to do with eye functioning and also cardiac functioning. You're not going to see that one as much. You're not going to hear about it as much. It's a smaller level electrolyte. So just kind of skim through those, skim through what you might see in your patient with magnesium. Same thing with phosphorus. They are important. I don't want to undermine them, but they don't have the significance that sodium, potassium, calcium have. The chloride, I'm on page 266 in your book now. Chloride is important because the reason this is an important one to know is because it's in a lot of the IV fluids you're going to hang. 0.9 normal saline. The normal saline is sodium chloride, Na+. plus and Cl with the anion. So it is important to understand your patient's chloride level, because patients who have been on normal saline, which is an isotonic fluid, if they've been on that chloride, the sodium chloride, for too long, it can actually contribute to acidosis because of the higher levels of chloride for too long. So you do need to kind of keep an eye on that. Moving on to acid-base disturbances, at the end of page 267, we talked a little bit about that in class. That should all be total review for you. So you just need to understand respiratory acidosis versus metabolic acidosis, and respiratory alkalosis versus respiratory alkalosis. And it has everything to do with what's going on in your patient. So if you have a patient who has COPD, lung cancer, asthma, they're hyperventilating, they're on a ventilator, all of those are respiratory. Those are all related somehow to the lungs. So the chances of your patient having a respiratory problem are high. If your patient has kidney failure, nausea, vomiting, diarrhea, they're in DKA, you're probably looking at a metabolic problem. It is in the kidney system. So you've got these two systems. You've got your lung system and your kidney system, and they work together to maintain this acid base. But if one of those goes awry, the other one will start compensating. The lungs compensate very quickly. So a respiratory compensation can occur very quickly. Metabolic compensation usually takes 24, 48, 72 hours to start compensating for the respiratory problem, just because your lungs, you breathe, several times a minute, and your kidneys, it takes a while for them to recognize, is there too much fluid, not enough fluid, is it acidotic, what kind of electrolytes do I need to hold on to? So we can go over that more in class if you have more questions about that. Also keep in mind that emesis and diarrhea have very high acid content in them. So if your patient is in a prolonged state of vomiting, this is true with your anorexia patients. Need to make a note here, because students mess this up all the time. There is a difference between anorexia nervosa, which is the mental disorder that teenagers have where they make themselves vomit. Anorexia nervosa is not the same thing as anorexia. Anorexia in your patients, like if you say that my patient's just anorexic, means they have lost their appetite, they don't want to eat. So if you have a patient who's anorexic / bulimic, where they're vomiting, they cause themselves to vomit, those patients can have major electrolyte problems because they're losing so much acid every time they vomit. So patients who have vomiting and diarrhea are probably in a metabolic alkalosis state because they've lost so much acid through, because there's a lot of acid in the GI tract. Okay, so we already kind of talked about the respiratory acidosis, alkalosis in class. We'll do some more. We'll do some case studies so you can figure out, is the patient, you can figure out which one your patient is. Don't worry a ton about compensation. You can usually figure it out pretty quick by which number is more out of whack. And if you're given a patient scenario, it's really helpful. So for example, if you have a COPD patient, you know right away it's a respiratory issue. You look at their acid base and you can tell that patient is in respiratory acidosis. Their carbon dioxide, which should be between 35 and 45, is probably high. It could be up in the 60s. And their pH is probably less than 7.35, so you know they're in a respiratory acidosis state. But then you look over at their bicarb and you'll see their bicarb is probably high, and you can tell that even it's a respiratory acidosis, one, because of the diagnosis, and two, because the carbon dioxide is so significantly higher. But you can see that bicarb, which is base, so the higher the bicarb is, the more base, it's trying to get higher and higher in order to compensate for the high levels of acidity. So a higher base and a higher acidity can kind of equal each other out. If you don't understand that, we can talk about it more in class. The chart 13.2 on page 274 is a really good walkthrough of acid base if you're still unclear about that. Okay, so now I want to talk about IVs. Parental, that the word para means outside of. Enteral is the GI tract, so this is outside the GI tract, somebody's getting fluid. The best way to get fluid is orally. The best way to do anything is how your body was designed. So if your body was designed to do something one way, that's the best way to do it. However, most of our patients need help or need compensation doing that. So sometimes they need parenteral therapy, meaning they need an IV. So you should all have already know how to insert an IV, how to maintain an IV, how to make sure it's not infiltrated, how to make sure that it's not getting eviscerated if some of the solution that's going through there is getting into the tissues causing evisceration. So I wanted to talk to you a little bit about the types of IV fluids. This is really important to understand and huge nursing thing. Not an intervention, just kind of like a thing. I'll think of the word. So your isotonic IV fluids, you've got two choices: 0.9 normal saline and lactated ringers. The 0.9 normal saline has sodium, some sodium and some chloride in it, and that's it. Your lactated ringers have sodium chloride and a couple other things in there. But both of them, if you give 0.9 normal saline or lactated ringers, when you start infusing that into the vein, there's no shifting of fluids. You're just adding fluid, but the fluid between all those compartments that we talked about, it doesn't change. Everybody's happy, everybody's the same, because the amount of water and the amount of solutes in normal saline and lactated ringers are identical to what the normals are in the body. So there's no shifting of fluids, which is great. If your patient has to be on an IV for a long period of time, lactated ringers are probably the better choice, because some studies have shown now that that normal saline can actually contribute to acidosis, whereas lactated ringers tend to keep that pH a little bit more steady. But just remember, both of them are isotonic. They're great if you just need to give your patient some fluid. They're great. However, there are times when you deliberately want to have fluid going into the cell or out of the cell. So that's when you would give a hypertonic solution versus an hypotonic solution. So I want you to know what they are. A hypotonic IV solution is anything with less than 0.9 normal saline. So, like it's 9% of sodium chloride in a 1 liter of distilled water. That's all your IVs are. It's a liter of distilled water, and it just has not even 1% of salt. It's 0.9% sodium chloride. Sodium chloride is salt. And if you hang that, or a lactated ringers that has lactate in it, anything less than that is hypotonic. So 0.45 normal saline, that's half of the salt, half of the sodium chloride. That's a hypotonic solution. D5 in water is a little bit weird, because you can't infuse just straight water into somebody, because all the cells will blow up way too fast. So you need a transport to get the water in. So if you add 5% dextrose or sugar, the sugar acts as the transport and can slowly transport the water into the cells. But so technically, D5 in water, if it's hanging in the bag, it's isotonic, but nobody cares what it does in the bag. So, but once it's in the body, it becomes hypotonic, because it's just water. There's not really any solutes in it other than that little bit of glucose. So once the IV is infusing in your patient, it becomes a hypotonic solution. Anything with more than 0.9 salt is hypertonic. So if you add 20 milliequivalents of potassium to your bag, if you're hanging a 3% salt solution, now you have more solutes than normal, and that becomes a hypertonic solution. So if your patient who is hyponatremic, now go back over here to this chart. Where was that? It's back towards the beginning. Okay, back on page 252. Go back to this figure 13.4. So let's say that your patient is hyponatremic, like, so your patient is in that top blue box. They're hyponatremic, less than 135. So let's say they're like 130. If you hung, and see how fat and swollen that cell is. So if you hung a hypertonic solution, so your patient's hyponatremic, I'm going to hang a 3% sodium chloride solution, so because I want them to have more salt, because they're low, so I'm going to hang that, and then you see what happens. So now the fluid shifts out of the cell because there's more solutes on the outside, and now I'm going to correct my fat swollen cells because I'm using a hypertonic solution. Do you understand how that works? The same way is if my patient is dehydrated, so let's go down to the bottom blue box in your hypernatremic patient. Let's say your patient is dehydrated. There's not enough water in the intravascular or intracellular spaces, and I want to add some water. I'm going to add a hypotonic solution. I'm going to add D5 in water or 0.45 normal saline. So now I've added a solution with less solutes in it, and now the water is going to start infusing back into that cell. So now my cells that are getting dehydrated are going to start increasing. This becomes super important in your patients because, like, for example, patients who have had head trauma, you don't want swollen brain cells. So you can reduce the size of those brain cells by giving a hypertonic solution, and you're deliberately going to shrink those cells to give the brain a little more space. You do have to be kind of careful with hypertonic solutions because it's easy to dehydrate your patient, but sometimes you want your patient a little dehydrated, like, for example, if somebody who has high intracranial pressure. So keep those different kinds of IV solutions in mind. We'll talk a little bit more about them in class. You should all know this stuff about how to give an IV and how to do IV rates and all that kind of stuff. You don't really need to know any of that information. Yeah, the rest of this is just all IV stuff that you should already know. Oh, one thing about air embolism, I'm on page 280 now. You can't inject air into the bloodstream. You'll kill somebody. A little bit of air can get in there, maybe a bubble or two, but if you inject somebody with 5 to 10 cc's of an air embolus, you can kill them because it'll act just like an embolus. So be very careful. That's why we always, when we're holding a syringe, we flick it so the air bubbles get out. So just make sure when that's why you have to prime your lines before you hook the IV up to your patient, because you don't want all the air that's in that line to get into the patient. That's exactly why you have to prime all your lines. Okay, yeah, so the rest of that stuff pretty much from page 275, 274, yeah, pretty much 274 on, you don't need to know, so I would just skip that. So, okay, so that's it. I would suggest maybe doing some of these critical thinking exercises on page 283. And challenge yourself. I would go on to the point, like the point thing that you guys have online. I would do some of those, the questions, the NCLEX questions and stuff on there. And then we'll go over more of this in class. But that should do it for Chapter 13, Fluid Electrolyte, Acid Base, and Hypotonic, Isotonic, and what was the other one? Whatever one I didn't say, fluid. Okay, that's it. See you next time.